I guess we can start. Hello, everybody, and welcome to VascAgeNet Webinar number 8. Check if it's working live. Yes. My name is Andrea Guala, and I'm Vice Leader of Working Group 5 and Leader of the Training Activity in the European Cost Action VascAgeNet. VascAgeNet is a network of researchers from Europe, the US, and Australia who are working together to refine, harmonize, and promote the use of vascular aging measures in order to improve clinical practice and reduce the burden of cardiovascular disease globally. Before we get started, I would just like to run over a few housekeeping points. Firstly, your microphone should be muted. If not, please make sure it is now. Secondly, this webinar is being live streamed on YouTube and will be recorded and shared on our website following the webinar. To ask a question, please type it in the question and answer box. Finally, we will not be able to assist you with any difficulties throughout the webinar. So it is my great pleasure to host this webinar and to introduce our speaker, Dr. Julio Chirinos. He is an associate professor of medicine at the University of Pennsylvania Perelman School of Medicine. He directs an extramurally funded research program at Penn, focused on the non-invasive assessment of cardiac and arterial structure and function using a combination of imaging modality, including echocardiography and cardiac MRI in patients with or at risk for heart failure. His lab has particular expertise in assessing arterial stiffness and its impact on target organs, particularly the left ventricle. He is also interested in proteomic approaches to understand human heart failure and in the cardiovascular aspect of COVID-19. Dr. Chirinos has published over 200 scientific papers, chapters, review, and editorial. He is Vice President of the North American Artery Society and an Associate Editor of Circulation Heart Failure and the Journal of Clinical Hypertension. He also participated in various working groups and guideline committees for the American Heart Association, the European Society of Cardiology, the American College of Cardiology, the American Society of Hypertension, the American Society of Echocardiography, and the European Society of Cardiovascular Imaging. Today, he will be speaking to us on heart-arterial interaction. Please, Dr. Chirinos, thank you very much for taking the time to speak with us today. I will now hand over to you.
Thank you so much, Andrea, and thank you to VascAgeNet for the kind invitation. I think you must be seeing my screen now. Can you confirm?
Yes, we do.
Okay. We're going to start the presentation. All right. Again, thank you for the honor of being here talking to you guys about this favorite topic of mine, which is heart-arterial interactions. And I'm going to gear it towards heart failure to put it in a clinical perspective. These are my conflicts of interest. And the reason I'm interested in heart failure, and particularly heart failure with preserved ejection fraction, is that heart failure is a huge public health problem. Just in the US, we have about 6.5 million adults with heart failure, and about half of them, in fact, most of them nowadays probably have heart failure with preserved ejection fraction. This is a condition with poor survival, frequent hospital admissions, poor quality of life, large costs for society. So it's an epidemic with personal implications for the patient and also societal implications for in terms of its burden of disease and impaired quality of life. Unfortunately, we don't really have good treatments for this condition. We have good treatments for HFrEF, which is the variety of heart failure with reduced ejection fraction. But we don't really have any proven effective treatments for HFpEF. There's some recent success in some subsets, but really not a clear, highly effective therapy for this population. And this used to be called diastolic heart failure based on the pressure volume loop concept of end diastolic stiffness. Some reports noted that these people tend to have stiffer ventricles. However, I think it's important to recognize that HFpEF is really a multisystemic illness. It has clear abnormalities in arterial function and structure, lung function and structure, neural reflexes are abnormal. There's a lot of metabolic abnormalities that play a role. Cardiorenal interactions are abnormal and probably very important in this syndrome, and so is mitochondrial or skeletal muscle dysfunction, as well as body composition. So this is really a hard problem to figure out, and I've been attracted to it through the arterial perspective, and we're going to discuss some of these issues today. So we're going to go back to just basic principles. I suspect most of you know this very well, but just to start from scratch, right? As you know, there is pulsatility. The pulsatile ejection from the left ventricle gets progressively dampened into continuous flow at the capillary level, or almost continuous flow at the capillary level, and that's largely due to the properties of elastic arteries such as the aorta. Now, this phenomenon of pressure drop over here that starts with smaller vessels is dependent on resistance, right? The mean pressure drop. And so resistance actually resistance vessels, and I'm talking about small arteries and arterioles, protect the capillaries against excessive pressure and excessive pressure fluctuations. But resistance is not uniform across vascular beds. In fact, if you look at blood flow, which considering mean pressure is very similar, at least in the supine position, is very similar across different organs, blood flow is very different. And this means that local resistance in the various organs is very different, because for any given mean pressure, flow is dependent on resistance. And so if you plot arterial blood flow, which again varies inversely with resistance, you'll find that the target organs are there among the high flow, low resistance beds. The kidney has been, the most widely cited and known example of this. The brain is said to also have very low resistance, but not nearly as low as the kidney. Certainly the placenta is an organ of very low resistance and highly vascularized. So is the myocardium and the liver. In fact, there are more recently, it's been recognized that the pancreas may be a target of arterial stiffening. And this is also an organ, the islet cells, the islets in the pancreas, actually have very high flow and very low resistance. In fact, have higher flow per gram of tissue or per 100 grams of tissue than the kidney. As you can see here, 50% higher flow. It could be even higher depending on the literature that you look at. And so other than the carotid body, which is basically a bag of blood with chemical sensors from nerve and nerve terminations, right, nerve endings, the islets are actually the second most highly vascularized and highly perfused beds in the body. So again, all these low resistance beds are probably the target of large artery stiffness, because that increases pulsatility and transmission of that pulsatility to those low resistance beds. And so not surprisingly, large artery stiffness has been implicated in a number of conditions that result from microvascular damage in these vascular beds. Subclinical brain pathology, cognitive impairment and dementia, chronic kidney disease, even testosterone deficiency. The testicle is also has highly vascular, highly perfused segments or areas, preeclampsia and intrauterine growth restriction, insulin resistance and NASH in the liver, and more recently diabetes. There's certainly a bidirectional relationship with diabetes and many of these other conditions, but there are mechanisms by which stiffness could actually precede these abnormalities. And that's been shown directly for some of these in epidemiologic studies. The heart is a special case because even though it has low resistance, high flow, its perfusion occurs in diastole. So myocardial contraction protects the microvascular bed in systole. So it's not really the same physiology. The damage to the heart occurs through ventricular arterial coupling and through coronary perfusion pressure in the aorta, okay? So now when we look at HFpEF, this population I've been talking about, they have stiff aortas. That's been shown early on, and that's been reproduced recently by other groups. And so this conglomerate of conditions that we see in these patients, in fact, may be at least partially due to aortic stiffening in this population. We do see this cluster of problems in patients with HFpEF. They not only have HFpEF, they come with CKD, they tend to exhibit high pulse pressure and systolic hypertension. In fact, almost all of them are hypertensive. They tend to have cognitive dysfunction, stroke, dementia, microvascular disease, and in fact, they also tend to have diabetes. So some of this clustering may actually be due to stiffening, and that's, I think, an interesting avenue to pursue in future research. Now let's talk about the heart. Again, the heart doesn't really get damaged from pulsatile energy penetration into the microvasculature because flow in the heart is diastolic predominantly, microvascular myocardial flow. But there's the coupling part, right? The heart's a pump, ejects against the arterial tree. So we gotta be thinking about the effects on the ventricular load or the arterial load on the heart and the ventricle and the coupling. And this is what I've been invited to talk about. And you know, the main way in which this has been looked at historically is the pressure volume plane. So in this paradigm, what you do is you acquire a pressure volume loop, you pair pressure and volume measurements in the ventricle, and you plot them in a pressure in the y-axis and volume in the x-axis. And you take a family of them. You do some preload interventions or changes, and you're gonna get different pressure volume loops. And then you take the end-systolic points of those loops and you join them with a line, and that's what's called the end-systolic pressure-volume relationship, okay? And that's assumed to be linear, and it has an intercept here called V naught. Now, when you have that, and you know this slope and this V naught, for which you really require a family, although there are single beat methods that allow you to guess this, then you can plot the relationship like this. So this loop, the area inside the loop is the stroke work, is the external work that the ventricle is doing. This is thought to be the potential energy accumulated in the myocardium. And thus, when you add these up, these two, the gray and the blue areas, you get what's called the pressure volume area. And that's thought to be a correlate of myocardial oxygen consumption. So this is very oriented towards energetics. And now later on, people said, okay, great. I can also plot this slope over here from end systolic pressure down to end diastolic volume. And so that this width over here, so end systolic pressure to 0 in the x-axis, in the y-axis, and end systolic volume to end diastolic volume in the x-axis, in the horizontal axis. So, and this width would represent the stroke volume. So, okay, if you know stroke volume and you know the end systolic pressure, which people say, okay, it's about 90% or so of systolic pressure in the arm, you can take this ratio and say, okay, this is an elastance as well. And you can kind of match those in the same units. And there are a lot of problems with that, but I just want to start here because most people take this paradigm as true. And in fact, in my opinion, it is one of the most overrated physiologic paradigms in cardiology, probably even medicine. And we take it for granted, but when you look into the detail of this paradigm, there are a lot of problems. Okay, so let's talk first about its merits. It is useful to some degree. It helps us understand determinants of stroke volume and ejection fraction. This pressure volume area, in fact, correlates well with energetic efficiency, but only when the ejection fraction is low, less than 40%. It does not correlate well when the ejection fraction is high. So for HFrEF, heart failure with reduced EF, it's a good model to assess hemodynamic responses or even predict them when you have some baseline data. It's good at predicting within subject changes, not so good at predicting between subject differences. This is very important, which is how we usually use this paradigm for. So, you can assess the operational efficiency of the LV, but that's only when the EF is low. And it helps you understand that when the EF drops below 40, then the energetics become quite unfavorable. So it does help you think about HFrEF, but it does not, in my opinion, help with HFpEF too much. I mean, it does explain why the EF is normal. It does give us some insights into stroke volume reserve. Essentially, if you have a high arterial elastance and a stiffer ventricle at rest, then you don't have a lot of reserve to become even stiffer during exercise and inject more blood, have this higher stroke volume. So it does give us some insights into that, stroke volume reserve. It could also explain why people develop hypertensive responses to exercise from a very stiff ventricle and things like that. but it really doesn't add fundamental insight into what's abnormal. It tells us about what may be normal, a couple of abnormalities it does explain, but it really doesn't add a lot into what may be abnormal in these people. And it has a lot of limitations. And I could spend a lot of time going through this, but then I don't want to really focus too much on this paradigm, because I want to get into what I think is much more useful, which is time-resolved analysis of pressure and flow and so forth. But we got to be aware, and you can check these reviews. There's an extensive discussion there as to why these limitations are there. But basically, oxygen consumption at the pressure volume area correlate well only within subject, not between subjects, because MVO2 depends on a lot of things. At the end systolic pressure volume relationship, it's in fact non-linear. So the linearity is basically made up all the way down to the x-axis. A common intercept is also a fallacy. In fact, it's been disproven. You don't have a single V naught. If you cross 2 or 3 pressure volume loops and project them, and you pick another group of pressure volume and systolic points and project them, you don't reach the same V naught. You don't arrive at the same intercept. So the whole V naught being unique is really not true. Chamber stiffness differs from myocardial contractility, right? Because the wall stress depends on geometric factors and wall thickness and things like that. It's not only a pressure volume phenomenon. Stroke work and efficiency are in fact optimized already over broad ranges of this ratio, as broad as 0.3 to 1.3. That is roughly EFs of 40 to 80%, which is where most, if not all, patients with HFpEF live, is in this EF range between 50 and 80. So it really doesn't help us address energetic efficiency at all in patients with preserved EF, in my opinion. It does help us with HFrEF, but not with HFpEF. The other thing that I have a lot of problems with is that in this paradigm, stroke work is the key parameter, right? This area, this external work. And that means that the paradigm gives equal credit to a system that's highly hypertensive, very hypertensive and a very low stroke volume, than a completely normal system with a nice stroke volume, a high stroke volume, and a normal pressure, because the area is the same and the external work is the same. But in one situation, you're very sick and you're going to do very poorly, and in the other, you're going to do very well. But your stroke work, your external work can be the same. And so this concept that stroke work is really the parameter to be optimized, I think that was, thinking of, past times where everything was hemodynamic and everything was about the output of the heart and so forth. And it's really not the way it is. Stroke work is not everything, right? Now we know about what the importance of pressure, just absolute pressure for all the organs, the importance of flow, pressure and flow pulsatility. We know about the importance of the loading sequence, right? Early versus late systolic load, which is completely neglected in this paradigm. In fact, any pressure above end systolic pressure here is neglected, and sometimes the loop has a shape like this, where you have a lot of pressure on top of the end systolic pressure from wave reflections, and the timing aspect, which is so important. So again, in HFpEF, limited fundamental additional insights. And finally, talking about arterial interactions, it focuses on this end systolic stiffness, the slope, coupled with an elastance, and that's also a big problem. Because if you think about it, what this paradigm calls arterial elastance is the ratio of end systolic pressure to stroke volume, right? So basically, it should be the delta pressure over the delta volume. Well, end systolic pressure over the delta volumes means that it assumes that the pressure variation goes from 0 to end systolic pressure. And I have never seen a human whose diastolic pressure is 0 in the arteries. So this paradigm doesn't really pan out. In fact, if you think about what this is, it's just a ratio of pressure over stroke volume, and end systolic pressure is very closely related to mean pressure. Okay, so if you just replace mean pressure in that equation, you come up with this being just entirely dependent on heart rate and systemic vascular resistance, which is a microvascular parameter. So this concept that we've been told, and in fact in medicine we get tested on this from medical school all the way through fellowship in cardiology, that this paradigm really tells you the net load that the arteries put on the heart. That's just incorrect. It's factually incorrect. Arterial elastance does not do that, okay? Because this is not the change in pressure. Pressure doesn't go from 0 to systolic pressure. And in fact, you know, if people that promote this EA concept say, well, this is a net load, that's resistance plus pulsatile load, it all comes together. And it's not the case. And Patrick Seegers from Ghent showed that very nicely with modeling, very clearly. But you know, physicians like to see data. So we collected data in a lot of people, thousands of people, in fact, and no matter whether they were young or old or diseased or not, we found that EA, as modeling had predicted, is basically just almost a perfect function of resistance over period. So that is the product of resistance and heart rate. That's it. You can guess 97 to 99.7% of the variability in a population in effective arterial elastance just with those two parameters. One is a heart parameter, is the heart rate. The other one is a microvascular parameter of mean of resistive load, which has nothing to do, at least from a biophysical standpoint, with pulsatile load. And there was, in fact, no relationship with pulsatile load, with wave reflection indices, or with arterial stiffness measured with gold standard methods. Okay. This paper is published. It has way more subjects than any paper that's trying to convince you otherwise. And it's backed up by really solid modeling data from Patrick. So, you know, I really do want you to think about this and to also think about these other more contemporary ways of approaching ventricular arterial coupling, which in my opinion is the best way. Which is assessing time-resolved parameters of pressure, flow, wall stress, volume, etc. And the way to do this is actually rather straightforward and rather easy. If you have the equipment and some experience in making the measurements, all you need is a high-fidelity tonometer that you put in a central artery. Some people prefer transfer functions. There's a controversy there as to what's the best way. We like to try to get carotid whenever possible. Or aortic, and basically it's even better if you're in the cath lab, and you get a flow measurement, which could, you know, you could have a flow wire, you can have an ascending pulse wave Doppler interrogations of the outflow tract. You can do it with MRI. At the end of the day, what you want is a time resolved flow waveform that kind of looks like this in the outflow tract, looks a little different in the aorta with a bit of reversal here, but it's essentially the same flow that's going out from the LV outflow is the same flow that's going into the aorta. And then you just model these pressure flow pair. And that does allow detailed analysis of arterial load and ventricular arterial interactions. And, you know, so basically the way I approach this in a simplified manner is at the beginning of systole, if you scale flow and pressure and you try to kind of put them on the same points here, in other words, scale these flow and pressure scales, right, to each other, then what you'll find is that the relationship between flow and pressure is consistent, and it's governed by characteristic impedance, which is the delta pressure of the delta flow. You could say it's the delta here over the delta here in this scale, if you make these points coincide, right? So basically, what is the increase in pressure that corresponds to an increase in flow? That's a local property of the aortic root called the characteristic impedance of that segment. And that governs the pressure flow relation, the pulsatile pressure flow relation, up to the point where wave reflections arrive back at the heart and dissociate this relationship, add to pressure and subtract from flow. So you get a divergence, and this area is in fact twice a reflected wave over here. And then in diastole, you get a decay that's dependent more certainly on reflections that are going back and forth. And at that point, the aortic valves close. So from the heart standpoint, you can easily think of this as more of a passive compliance type of property that's releasing energy into the veins. And that's modeled with Winkesel models and so forth. But it's important to understand that there's no infinite pulse wave propagation or instantaneous pulse wave propagation in the arteries. This is just a way of thinking about this low frequency diastolic decay that happens in diastole and some of the load that happens in systole as a compliance. It helps engineers model the system, but it's just not physically correct. It doesn't happen that way. We live in a spatial world where it takes time for energy to travel through the aortic wall back and forth. So there's nothing instantaneous about it in reality. It's just a modeling approach. Now, so under ideal conditions, the pulse wave travels through the aorta, bounces back and comes back to the heart. And when you have a low wave speed, that nicely arrives at the heart in diastole. And when the aortic valve is closed, so the heart doesn't see those reflections, doesn't have to pump against those reflections. And in fact, those reflections increase coronary perfusion. So it doesn't increase afterload, and it increases diastolic perfusion. That's good. That's a good reflector wave when it's timed like that. Problem is that when the aorta is stiff, these phenomena are much faster. There's high pulse wave velocity or high wave speed. There's back and forth travel very quickly. And you get these early reflections that arrive at the heart in systole and augment systolic pressure. On top of what's already a high characteristic impedance from the stiffening of the root, right? Unless your aorta happens to be dilated. If you have a normal size or a narrow aorta and it's stiff, you're already going to have high load in early systole from characteristic impedance, and you're going to add to that load with the reflector wave. So it's bad to have stiff arteries in terms of coupling. So those reflections that return during systole increase mid to late systolic load and affect the loading sequence. And I want to start talking about this loading sequence, which is this late load, late systolic load, which is important. And of course, reflector waves have variable magnitudes. You could think about the reflector wave advancing from diastole to systole as you get older, and that's bad. This is an oversimplification, clearly. There are many factors to consider here, but it's useful from a conceptual standpoint to think about systolic reflections, really trying to move them into diastole, and that is a good strategy. And it's interesting because the only strategy is not stiffening the aorta. You can actually do this through manipulating muscular arteries, because you may change the phase of reflections and things like that make the reflector wave appear later. But we'll get into that. So. Now, why do I say that the loading sequence is bad? It's because we have data. We have data that started in animals and went through human studies, and I'll go through that very quickly. This started a long time ago with this interesting mouse study where they clamped the aorta either very proximally or distally right before the renals. So they induced a massive reflector wave coming back at the heart really early. So that would mimic a high characteristic impedance, early load, or they did a very low, clamping or narrowing that would induce a massive reflected wave, but it would arrive at the heart in late systole. So here you had early systolic loading, here you had late systolic loading in red. But the same systolic pressure. It was just the loading sequence that was different. And so these, some of these bars are just shams, please ignore them, but these are the two bars here that we're interested in. And you can see that the peak LV pressure was the same in both models, but the model that received the reflector wave in late systole or the descending aortic constriction exhibited much more LVH, and although I do not show that here, also much more LV fibrosis. This was demonstrated ex vivo. So then we looked at humans, and we did this study in the multi-ethnic study of atherosclerosis, where we estimated reflected and forward waves. A disclaimer here is we didn't measure flow. We used what's called a pseudo-flow approach, which is an approximation. Nevertheless, very large number, I think. Clearly, the reflected wave was related differentially than the forward wave to LVH. So really, the more reflected wave, or really this ratio, you see the sign of the beta coefficient or the standardized coefficient was inverse, was different, was positive and negative, and the value was clearly on the reflected wave as a positive correlate of LV mass, and that's adjusting for every variable we could think of. And this is MRI-derived LV mass. This is the gold standard LV mass. Hashimoto and colleagues also showed that when you treat people and you reduce their reflector wave with treatment, those are the people that regress their LV mass when you measure it 6 months later. I believe it was 6, might have been 4. Sorry, I don't remember very well. I'm pretty sure it was 6. But so clearly you have a temporal relationship there. When you intervene, reduce reflector waves, and then you can see reductions in LV mass. So again, supporting the animal studies. What about the fibrosis that I showed you in the mice? We hypothesized this in patients with, in this study that we had the opportunity to do in patients with aortic stenosis. Those people have a lot of LVH and fibrosis, and we wanted to pick up dynamic regression. When you replace the valve, the ventricle regresses, there's LVH reduction, and so we wanted to see, and fibrosis as well. There's fibrosis turnover at that point. So we wanted to take people who were getting fixed, right? They had severe aortic stenosis and they were getting a prosthetic valve. So basically the stenosis was fixed overnight, but they were left with their arterial load. So everybody received sort of the same intervention. At that point, the valve's okay, but these people have calcified aortas and various abnormalities in pulsatile load. And we thought, okay, we're gonna measure their load, their arterial properties, and see if that impacts their improvement after valve replacement. The arterial load that's left, because that's what the heart sees after you replace the valve. So we measured these with MRI, and we measured fibrosis with MRI T1 mapping, and we measured input impedance with flow and pressure and tonometry, and we did wave separation analysis with standard methods. And what we found is that reflection magnitude was first, it was a correlate of fibrosis even before you replaced the valve. And in fact, the aortic characteristic impedance was not. In fact, it was the other way around, probably because of dilated aortas in this condition. So these patients had just, if they had bad reflection, if they had high reflections, that was bad news. And of course, these are people with stiff arteries. So these reflections were predominantly systolic reflections. And people with high reflection magnitude exhibited the most fibrosis or extracellular mass, which is the hypertrophy of the extracellular compartment. That's the worst part. When they got replaced, when their valve was fixed, their quality of life improved, but not to the same degree. Some people improved a lot, and some people actually didn't improve or even got worse. And when we plotted the delta in the quality of life score, this is called the Kansas City Cardiomyopathy Questionnaire against reflection magnitude, we found that people who had high reflections, those were the people that did not improve or even got worse, whereas people with low reflection magnitude are the ones that improved. So when we fix the valve, the heart starts seeing these reflections. If there's a good pulsatile load pattern, they do well. If there's not a good pulsatile load pattern from the arteries, they don't do very well. In fact, they can get worse, believe it or not, some people. But in general, their magnitude of improvement was much smaller. If we split the population by median reflection magnitude, you can see how much these guys improved, people with low reflections, versus how little people with high reflections improved. And that was highly significant. And this related to various components of the score. So there's certainly a relationship with hypertrophy and with fibrosis. What about function, even before chronic remodeling? This was nicely shown by Terry Gilbert from Ghent as well, who instrumented dogs and inflated a balloon in the proximal aorta either early or late in systole. So he could manipulate and induce a pansystolic load starting in early systole. And this wasn't marked pressure. Look at the pressure that he increased. This wasn't a lot of pressure, but the timing was everything, right? Selective late or early. And what he found is that when you load the heart a few extra millimeters of mercury, you certainly induce diastolic dysfunction in the next beat. But the magnitude of delay in relaxation, this is tau, this is the isovolumic relaxation time constant. This is how fast the heart's basically relaxing and generating negative pressure. That was prolonged much more for any given millimeter of pressure, millimeter of mercury of pressure in systolic pressure increase, when the inflation of this balloon in the aorta was late. So when he induced late systolic load, he could see much more prolongation of tau, so much more diastolic dysfunction than the same amount of pressure imposed in early systole and sustained throughout systole. So clearly the sequence, it was not just about how much pressure there is, but how is that loading sequence being delivered? And that depends on the arteries, right? In the absence of a balloon in the aorta, that depends on wave reflection. We then looked at, okay, if this is true, and the best way to look at chronic diastolic dysfunction is how your atria are doing. The left atrium is really tells us chronic diastolic function. So we did this study in which we did LV measurements of ventricular geometry, time resolved, we measured flow, we measured LV mass, we measured carotid waveforms, and we computed time resolved wall stress in these people. These were axisymmetric ventricles, so these are approximations, but very useful to look at the time progression of wall stress. And what we found is that, of course, you had people that, as is normal, as we've been shown, most people who don't have a lot of wave reflection have a really early wall stress, and it really drops in late systole. That's what you want, because that's normal. And the ventricle, in fact, is relaxing here already. The myocardium is relaxing, even in late systole. But when you have prominent wave reflection, and this is kind of an extreme case where you have this massive secondary peak with obliteration of flow, look, it's almost concave here. You have this very late peaks wall stress, very pronounced bump in wall stress, which is non-physiologic, right? And so people who had this, in this case, in the Asclepios study, this was an echo study. I'll show you the left atrial data in a second, but in the Asclepios study, where we did identical analysis with echo, large population of normal people, we found that the late ejection phase wall stress related to the E prime velocity, which is basically it's a surrogate of relaxation velocity. So that dog finding that Dr. Gilbert had reported was, again, supported by human data. It showed exactly the way you would expect it to be if you looked at the dog data. And in fact, the directionality was very clear. Late ejection phase stress was related to lower relaxation velocities, whereas early ejection phase stress was not, because that's a measure of contractility. Myocardial contractility, and myocardium that contracts well is myocardium that relaxes well. So that actually correlated with good diastology. Similarly, when we looked at left atrial strain, I tell you, the left atrium is more, it reflects chronic diastolic function, and it's a very good metric of that. So we measured deformation of the left atrium, which also depends on chronic fibrosis and function. It really, the left atrium really sees problems when there is diastole and experiences a lot of abnormalities in remodeling. And so we found clearly across the board, no matter what left atrial measure we looked at, that across tertiles of early versus late wall stress, people with late wall stress really had impaired left atrial function, lower strain in any domain. And there was a gradient, of course, there in most parameters, as you can see here. Now, what about, so those are metrics of remodeling dysfunction. What about actual heart failure risk? We had looked at this in the multi-ethnic study of atherosclerosis as well, that I told you about, where we saw that patients with high reflections in this study exhibited a high risk of heart failure. And in fact, reflection magnitude, when you looked at the strength of the relationship, was much stronger than many of the known parameters of known risk factors for heart failure. So the strength of the relationship was actually quite significant. So the adverse consequences of wave reflections on the heart have been demonstrated in animal models and induce LV fibrosis, diastolic dysfunction, LVH. In humans, there's a relationship of LVH, regression of LVH, diastolic and left atrial dysfunction, the presence of HFpEF, abnormal adaptations to exercise even within a HFpEF population or a HFrEF population, as was shown in the old days by Lasky, LV fibrosis, and incident heart failure risk. So across the board, you have really the whole spectrum of trouble from ventricular arterial coupling. A lot of literature supporting that this is badness. Okay, so this is a summary. Good reflections in diastole increase your myocardial perfusion. Reflections in systole, not good. They tend to induce myocardial fibrosis, hypertrophy, and diastolic dysfunction. And this is the paradigm that we're working on. It's still not the complete story. We still have to figure out how this works and when different proximal aortic properties are present, for example, interventricular interactions, there's pericardial restraint. There's a lot of issues here to consider, but this is a general paradigm that I think is supported by current data. The interesting part is that, yes, the aorta is stiff. It's hard to change it at that point when it's calcified and so forth, but muscular arteries can modulate the apparent distance to reflection sites. And engineers will understand the phase of wave reflection. And you can change the phase at the muscular arterial level to appear later. In other words, to shift the reflected wave towards diastole. And this is a trick that one can apply with specific modulators of vascular tone. And so this is apparent, again, this is an apparent distance. It's not a real distance because the reflected wave shifts phase. It shifts a little bit when it reflects. It's not the identical version that gets reflected back. It's a version that's a bit shifted to the right or the left, if you will, over time. But nevertheless, the impact on what the heart experiences is the same. It essentially sees a later reflected wave. So, and I mentioned this because once you have this aorta and you're 80 years old and you have chronic kidney disease and HFpEF and you come up with this aorta, I'm not too optimistic that we can give medication to change this. Perhaps mechanical intervention someday would allow us to fix this, but not pharmacologic therapy. But muscular arteries we can work with. These are dynamic, dependent on tone, and so reflection magnitude is actually quite significantly modulated, we think, at this level. And of course, the microvasculature is important in HFpEF as well, right? Resistance vessels during exercise have to dilate, but very, very coordinated, in a very coordinated fashion. You need the flow to go to the muscle, and you need the flow to be shut down everywhere else. So you actually have vasoconstriction almost everywhere, but marked vasodilation in muscle when you're running, for example. You want the blood where it's needed, where the oxygen is needed. So this redistribution is key, and that's a microvascular property depending on local regulation. And the vasoconstriction is a systemic neural response from neural reflexes, right? When you don't have this vasodilation, you develop hypertensive responses to exercise, reduced cardiac output reserve, impaired coronary blood flow reserve, and so forth. And we know that this resistance or this vasodilatory reserve is abnormal in HFpEF. So we think that an ideal vasodilator for HFpEF is one that reduces pulsatile load, wave reflection, in fact, shifts the reflected wave towards diastole. We don't really want to reduce SVR at rest because that may cause hypotension in these older people. We certainly want to increase microvascular vasodilatory reserve during exercise. And there's a pathway, and I don't have a lot of time to talk about it. Just very briefly, there's a pathway of NO generation, nitric oxide, that's different to this classic pathway from the endothelium that depends on nitrate and nitrite, which is dietary supplementations coupled with oral bacterial reductases that produce nitrite, and you swallow saliva all the time, and you absorb your nitrite all the time from this nitrate that you're continuously secreting into your saliva, which in turn is derived largely from dietary sources. So you can actually supplement nitrate, get your bacteria to work, and give you a continuous infusion of nitrite, if you will, going down and absorbed in the stomach. And so in that, what that allows is hypoxia-dependent microvascular dilation, because the oxyhemoglobin and the oxymyoglobin actually are nitrate reductases that reduce nitrite reductases that reduce nitrite to NO. But also, very recently, Andy Weber in the UK has shown that you can, at King's College in the UK, he has shown, and his group have shown, that you can actually modulate muscular artery properties with this agent as well, such that you can actually shift the reflector wave towards diastole. And we actually happen to be lucky to publish our paper about wave reflection in HFpEF and improved exercise tolerance in HFpEF with a single dose of inorganic nitrate in the same issue that Andy and his team published, this new biochemical mechanism that actually happens to explain it perfectly. So it was an interesting coincidence there. So we're working with this. It's 44 after the hour, so I'm not going to go into much detail. I'm going to skip a lot of these. Happy to discuss later. Suffices to say that acute studies support the utility of inorganic nitrate. Not so with organic nitrates. Organic nitrates have lots of side effects, vasodilation in the brain, headaches, fatigue. And the reason is they're not selective like inorganic nitrate, we think. When we've measured vasodilation in the brain with organic versus inorganic nitrates, we've seen that carotid characteristic impedance really drops and resistance really drops with nitroglycerin, which is an organic nitrate, and not so with inorganic nitrate. And reflections, in fact, drop more with inorganic nitrate. So I'm going to leave that there. I'm going to skip the discussion of inorganic nitrite. This is more for those of you who are interested in HFpEF. I just going to mention that we're doing a long-term or a 6-week intervention now, almost done with this trial. It's taken us several years, and COVID didn't help. Our last year, we almost had to completely stopped the trial during COVID times. We're now reinitiating assessments and enrollment. We're almost done, but again, we want to do it right. We want to finish it, and we want to get the right answer, and that takes time. But hopefully, we'll be done very soon. We don't know the answer to that yet. We don't really know if it works, right? And finally, just to mention that interventions in the aortic wall, that's really the holy grail. We ought to be thinking how to prevent these long-term changes. There are multiple mechanisms. Those of you on the call who are into basic mechanisms of disease, we need you to inform us in how we should intervene here in clinical trials. Okay, I'm going to stop there, perhaps just wrap it up with some conclusions. Arterial abnormalities are important in HFpEF. We think it's important to move beyond the pressure volume plane towards more specific analysis of heart-arterial interaction. Potential therapeutic targets in the arterial tree include large artery stiffness, wave reflections, microvascular vasodilatory reserve, and rarefaction. We haven't talked about that too much. The non-invasive assessment of pulsatile load and coupling and interactions between the heart and the arteries is now highly feasible for drug development, for mechanistic studies in humans. We know that arterial abnormalities are important in HFpEF, need to be further investigated. We know that late systolic load is important, and we ought to be treating and addressing it in clinical trials to see if that really can change the outcome of patients. Vasodilatory reserve is another therapeutic target. Inorganic nitrite perhaps is one of those ways in which we can do that. We'll see. We're doing a phase 2b trial. We'll see. Many things have failed in HFpEF. Unfortunately, it's a very tough illness to crack, right? But we'll keep trying. I haven't talked about this, but vitamin K dependent MGP carboxylation is a mechanism to reduce calcification of large arteries over time. May actually be interesting to try in clinical trials, but it has to be thoroughly studied in randomized trials. And that's all I have. I want to leave some time for questions. So I thank you all for your attention. I want to thank again the VascAgeNet and mention that our lab's now recruiting postdocs. So if any of you is interested in joining us, we'd be very happy to talk to you about the opportunities that we have. And thank you all. Thank you so much.
Thank you, Julio, for this very interesting overview. It's been very interesting and really broad. Touching on many topics, many of them relevant for arterial health and about possible consequences of large artery stiffness, but not only large arteries. In particular, in my view, it was very interesting the critical analysis of pressure volume loop, which may not be the dogma that seems to be, and there's some limitation. It's important to keep it in mind. Before starting with a question from the public, I would like to take the advantage of this position to ask you a question about the perception into clinical practice. So nowadays, there is a growing evidence about the role of large and middle-sized arteries and even small arteries, as you mentioned, into the the implication for the heart, the left ventricular function, and possible disease. What is, in your opinion, the perception in a broad sense in the clinic, and how much is it really getting to the physician at large?
Very good question. I think clinicians who are thinking about heart failure do recognize, and hypertension, of course, do recognize that this is an important problem. I think where I see some barrier is it's technically a little complex. Understanding all these paradigms, it can take a lot of thinking, right, and a lot of learning about biophysics and mathematical modeling and analysis that clinicians are just not intrinsically familiar with. That's really not what we deal with on a day-to-day basis. So it really takes diligence and dedicated interest and an effort to say, I really want to understand this, and that takes time and that takes effort. So not everybody has really the time or is willing to really put the effort into this. So that's a barrier. I think our job is really to try to simplify this. And I know there are a lot of engineers in the group I really like engineers that talk at my level. They have to come down, 10 levels to talk like a clinician. And those are really the ones that I understand and I've been able to collaborate well with. I'm trying to understand engineering, but also, and it goes both ways. Some of the biomedical concepts, we really have to learn how to communicate to engineers as well, because that's really not what you think about every day in the clinical concepts. So these multidisciplinary societies like VascAgeNet, like North American Artery, like European Artery, Pulse of Asia, where you have these engineers talking to clinicians and physiologists and biologists. And we probably need more biologists in these societies over time. But I really enjoy going to these meetings because, and these symposia like the one we're having now, because it really takes this sort of interaction to get familiar with what's important, what's real, and what's not, right? But I'll tell you, in the clinic, there's recognition of its importance. There's no question about it. I think if we were able to simplify the understanding of it, but also the measurement and the assessment at the bedside, this may not be the case in every country, but medicine is very fast in the United States. You only have 15 minutes to see your patient, and you have to do a lot of things. And you cannot take 5 minutes to, or even 4 minutes may be a long time to assess a phenotype that may not change practice right away. And so we really have to get better at simplifying the acquisition of these signals and the analysis of these signals. Doing an echo is easy enough. I really think that the echo lab is a good opportunity to introduce pressure measurements. And for that, tonometry is great for research studies and gold standard assessments, but you're never going to get clinicians to use high fidelity tonometers. That's just not going to happen, not in the US, in my opinion. And so simplified methods of acquiring waveforms and trying to get at least approximations, I think we have to be a little more pragmatic about accepting some error there if it's going to allow us to actually start applying what we know and helping people, and not just staying at theory, at very stimulating discussions, but at the end of the day, we actually need to go to the bedside and help people. And so that's something that I want you also to think about as engineers, or those of you who are engineers in the group. And I know you've been talking about devices in this forum, right? How do you make it super simple? Think about something that can be done really fast and can be done by a non-clinician and a non-trained person. Something that is as automated as possible, even if it's not the gold standard. For research, we all want gold standard metrics. We can measure things and so forth. So understanding is one, measurement of the signals is another. And then the third one, which is entirely on clinicians, is once we're able to do that, how to use the information to make clinical decisions. It's good to know something about your patient and to understand it. There's already value there, even to just explain to the patient what's wrong, what may be going on, how we may be able to change things. But without clinical trials that target those abnormalities with a specific intervention, whether it be a lifestyle intervention, a medication, and that we can change it, and that will lead to better outcomes, whether the patient feeling better or the patient doing better over long periods of time, not getting hospitalized, not dying from their illness. That is hugely valuable. And so there's a stepwise process that we need to pursue. It takes time. Just doing a trial takes a long time. But we got to do it. And I think if we want to succeed as a field into this century, right? We need to be thinking about how to make this happen as a community, and really translate this to the clinic. And that's not just up to clinicians or I think we need to work together.
Yeah, thank you for the very interesting perspective. Actually, one of the main aim of VascAgeNet is indeed to refine and harmonize a measure of arterial aging, which in many cases it refers to arterial stiffness. So honestly, there is a very good large group of people with very broad expertises, and we really hope that all along the 4 years experience of this cost action, we can add a bit of help in this way. I understand that in the clinical practice, time is running very fast. And it's running very fast also for us now in this webinar. So I will try to put together a couple of questions that we received from the public. And we have a question about ankle pulse velocity, and then another about vitamin K antagonist. So in one sense, I think the aim of the question was if middle size and peripheral artery stiffness plays a role and may be modulated more easily by drugs. Do you think that measuring stiffness over a path, including middle-sized artery, could be some advantage for the monitoring? And the second question is related to vitamin K antagonist. Do you suggest to test for arterial stiffness in this kind of patient?
Yeah, thank you for that that question. Brachial ankle pulse wave velocity. I know it's easy to measure, but we have to recognize it's a composite of large artery and muscular artery stiffness. So the way we're using pulse wave velocity now, we're trying to promote the use of pulse wave velocity because that's where we have the evidence, is for risk prediction. We yet don't have evidence that modulating that has any utility. We have evidence that we can predict risk from multiple cohorts. So what we're trying to do is just do risk prediction as accurately as possible, because risk prediction will modify what we do for years, decades even, in terms of your baseline risk of having, and in large numbers of people in the population. So for this, we need to be as precise as possible, okay? And certainly carotid-femoral pulse wave velocity is our gold standard. Again, that's also not going to happen in the clinic. We need to find alternatives. But I tend to believe that alternatives that stick to the segment of the aorta are going to be better than alternatives that also include muscular arteries. And I think that's logical, and that's what the data supports.
So maybe non-invasive imaging.
Non-invasive echo is a very good way to measure transit times. Echocardiography. You can measure transit time between the root and the diaphragm in about 3 minutes in the echo lab. You need some post-processing of that, but artificial intelligence, for example, could accomplish this very easily. If any of you is into AI, let's talk, because this is a way of using it in a very practical manner. And you could estimate the arterial length of the thoracic aorta, with basic measurements, even just height and sex and gender, maybe even race. And so you could get a pulse wave velocity in the echo lab very easily. So the echo community is, I think, a target. It won't be able to be done by clinicians, primary care clinicians on the bedside, but I think, again, we also have to pursue that, right? Devices that are simple, that try to stick to, try to exclude muscular arteries. When you say, okay, modulating drug effects, we'll have to see. Maybe for that purpose, including muscular arteries may have some role, but I tend to think that to the degree that it's a composite, you're never going to be able to separate one from the other. In order to measure wave reflection, I'd much rather just get a waveform somewhere and do even pulse wave analyses or pressure flow analysis is really the way to do it. Even some pseudoflow approaches may actually be useful for that purpose, or physiologic flow waveforms, things like that. It can be done. The triangular wave is just the first step. There's ways of doing it much better. About vitamin K, very interesting question. Warfarin does calcify your arteries. That is at least in animal models, or in clinical reports, there are patients that calcify tremendously. I mean, they actually, some people actually have calciphylaxis, that they deposit calcium everywhere in the small vessels. But if there are studies that look at calcification of the aorta, even with X-rays, and you can see calcification over time in chronic users. And we know the mechanism. It's NGP. It's carboxylation of matrix glycoprotein, which depends on vitamin K2 predominantly to become carboxylated and thus be able to inhibit calcification. And so warfarin inhibits that process. So again, thankfully, warfarin is sort of moving away. Now we have different types of oral anticoagulants that are displacing warfarin. This would have been a much more relevant issue 10, 20 years ago. It's still relevant because a lot of people are still on warfarin. And that's a very good question. Should we monitor arterial stiffness in patients? Very good question. We don't have evidence. I don't have evidence to give you an answer, but logically, my gut feeling says that if you were to start monitoring these people, you would be able to predict trouble down the road. I think this is a beautiful study. If one of you who has access to this population wants to do, is to start a cohort of patients initiating warfarin in a warfarin clinic and measure their arterial stiffness and see how it varies, how it changes over time, who progresses and who does not progress, and measure biomarkers of that progression. I bet you MGP levels or measures of calcification or calcification inhibition may be related to that. So there's good hypothesis to be pursued there if someone has an interest. I don't know of anybody that's really doing that. Some people are testing vitamin K2 supplementation to reduce aortic valve calcification, for example. I know there's been a trial to reduce aortic calcification, but the results of that trial weren't all that clear. I think we need bigger numbers and perhaps select patients that actually are going to calcify more rapidly in the absence of vitamin K2, and people who actually have the deficiency. So people who have a high MGP level, for example, could potentially be good candidates. So we have to think more about how to execute those trials. But I do think that there's something to be learned about vitamin K. It could be a very easy intervention, presumably a safe intervention, although we have to prove that. But I do have hopes that vitamin K may have a future in that regard.
Thank you, Dr. Chirinos, for this very interesting talk. Lastly, in the interest of time, we will bring the webinar to a close. Thank you very much for giving up your time to present to us, and thank you for all attendees and participants. So we will be hosting future webinars every month throughout 2021, and we look forward to welcoming you then. From Dr. Chirinos and I, goodbye, and see you the next time.
Thank you all, and thanks again for the invitation.